I have the privilege of beginning the session. I'm the moderator, and we'll also be giving the first couple of talks. The first of these is an overview on the diagnostic evaluation and medical management of lymphedema. Well, one of the problems, of course, with lymphedema is that it has really not arisen to the level of clinical importance and comprehension that we might hope. And fortunately, during the 20 years or so that I've been doing this, it is certainly rising in comprehension and recognition, but we still have a long way to go. We know that it's really a common and prevalent disorder that can affect literally any part of the body in which lymphatic flow can be impaired, so typically the extremities, the foot, the hand, the arm, the leg, but also, of course, can involve the face and other structures of the head and neck. In all respects, wherever it occurs in the body, we need to think of it as the evidence of system failure of the lymphatics. So as clinicians, we're used to thinking of the various organ systems in the body and the failure states that are engendered when that system doesn't work properly. So as a cardiologist, I recognize, of course, that when the heart is not able to perform its contractile function normally, we have congestive heart failure as the end result. If the pancreas fails, we have diabetes. The kidney fails, we have uremia, and so on. Well, if the lymphatic system fails regionally or systemically, we have lymphedema as the disease state or set of presentations that will occur. We need to acknowledge that lymphedema is a chronic condition. It is debilitating to patients. It's frequently misdiagnosed. It's often treated too late. And unfortunately, still for our patient population, it's often not treated at all. The hallmark of every stage of edema, including lymphedema, is the presence of pitting, or the ability of the examining finger to move the fluid within the swollen structures, at least temporarily, enough to define how much fluid is there and the fact that it is still fluid in consistency, in its consistency. A specific physical finding of lymphedema that was described back in the 1970s by a German internist named Stemmer is this so-called Stemmer's sign, in which if there is lymphedema in the feet, there is an inability to tent the skin at the base of the digits, which reflects the thickening of the tissues that is relatively unique to lymphedema as a disease condition. The International Society of Lymphology has elaborated a staging sequence that in essence is based upon either the presence of pitting or its gradual disappearance as other attributes of the disease emerge. So the ISL has defined actually latent disease as stage 0, which would mean that there is some way to detect that the lymphatics are abnormal, typically by an imaging modality, despite the fact that no edema can be elicited. Stage 1 is the sheer presence of pitting, which largely subsides with elevation. So the very earliest phase of the true edematous condition. And then as we progress down the sequence, you can see that there is an increasingly reduced ability to clear the pitting edema component as simultaneously there emerges the tissue component that we know uniquely affects this disease state, and which we'll talk about a little bit more in a few moments. Those of you that were present at the first session already saw a version of this diagram, but suffice it to say that in the normal functioning of the lymphatic system, we have an attribute which we call the lymphatic load, which is the amount of lymph that is formed, or interstitial fluid that is formed per minute or per unit of time. And we have a transport capacity, which is generally dictated by the density of the lymphatic vasculature as well as its structural integrity and its functional integrity. In the bottom panel, we have, I think, what we're most used to thinking about, which is the lymphedema that emerges after cancer therapies or after trauma, in which through the changes that occur surgically or through radiotherapy, there is a reduction in lymphatic transport capacity because the lymphatic structures are simply surgically excised or damaged through radiation. And then a normal lymphatic load will not be able to be handled adequately. There will be an accumulation of excess fluid in the tissues, and lymphedema becomes clinically manifest. However, bear in mind, and we should certainly do this in a meeting specifically devoted to the veins, we can have normal lymphatic transport capacity but dramatically increased lymphatic load, as might occur, for example, after deep vein thrombosis and chronic venous insufficiency and post-phlebitic syndrome. Anything that increases the afterload on the blood vascular capillary will increase the amount of interstitial fluid formed per minute, and at some point this can overwhelm even the maximal capacity of the lymphatic system to transport that fluid, and we will get the same pathological endpoint, which is all of the changes that we described with the ISL classification. So when we talk about the problem of lymphedema, the first order of business is to decide whether it's primary or secondary, and let me say that this distinction is not absolute but relative, but nevertheless it is the way in which we've traditionally thought of the problem. The primary lymphedemas can either be congenital or appear at other points in the natural history of the individual. The secondary lymphedemas are considered either benign or malignant. Now, this is not based on pathogenesis, meaning if somebody has lymphedema after cancer therapeutics, it is not malignant lymphedema. That's still a benign lymphedema, assuming that the cancer is quiescent. The malignant lymphedemas are designated when there is direct structural obstruction of the lymphatics by tumor itself, and it actually has quite a distinct presentation to the more benign form. In the primary category, we need to think about the genetic diseases like lymphedema distichiasis, for example, in which lymphedema is accompanied by a very distinctive development of a second row of eyelashes. I'll talk a little more about the genetic issues in the next talk. And at the other end of the spectrum, the purely acquired diseases, the one that is incontrovertibly acquired is lymphatic filariasis. Fortunately, we don't have a problem with this in North America, but in endemic regions of the world, chiefly Asia Minor, Africa, and in portions of the Western Hemisphere in Haiti and in Brazil, this endemic infection with a nematode worm leads to the inexorable destruction of the lymphatic vasculature and a quite severe form of lymphedema that we typically call elephantiasis. Now, what about diagnosis? Well, central to the diagnosis of lymphedema is a well-educated clinician. I hope that's why we're all here this afternoon, because I think lymphedema can largely be accurately diagnosed in the clinic and at the bedside. When there is a problem or there is any question about whether it's a lymphatic origin for the edema, we do have imaging approaches. But again, I want to emphasize that the clinician is central to the diagnosis and the imaging is only ancillary. So historically, what we did in the middle portion of the last century, chiefly and largely abandoned except in very specific circumstances, and we will be hearing about some of those in tomorrow's session on vascular malformations. Early on, we used a lipid-bearing radiocontrast that was directly introduced into the lymphatic vasculature via, historically, a cut down on a small lymphatic injection of a vital dye to establish the identity of the lymphatics, and then entry of those small vessels and injection of the contrast at that point in order to see the distribution of the vessels as they ascended toward the heart. This has largely been abandoned both because of technical issues, it's very difficult to perform, time-consuming, laborious, but also because the contrast agent may be directly injurious to lymphatic endothelium. The hallmark today and what we would call the gold standard for lymphatic imaging is radionuclide lymphoscintigraphy. This relies upon the injection into the subcutaneous space of a radio-labeled agent that has obligatory lymphatic transport to be cleared so that we can follow its transit from the point of injection, in this case in both hands, up to the draining lymph node-bearing areas. So we look at both the transit time to appear in the lymph nodes as well as whether there is complete clearance of the material at the level of the nodes or whether there is back leakage into the tissues, which we call dermal backflow. So this is the abnormal side in which there is both very dense dermal backflow as well as very delayed appearance of the imaging material in the lymph nodes. Now I want to emphasize this is a wonderful way to diagnose lymphedema, but it is a functional imaging test. It does not really tell us much, if anything, about the structural attributes of the lymphatic vasculature. Here's another example in the legs, and this is that same syndrome I showed you, lymphedema distichiasis syndrome, which is characterized actually by lymphatic reflux because the defect is actually in the valve formation in the lymphatics. And here you see this dense dermal backflow. Looks like the individual is wearing black boots. That's all reflux of injected material that initially gained entry into the lymphatics and then exited again because of incompetent ability to have forward flow. Here's another example of dermal backflow as well as delay in the appearance in the draining lymph nodes. Now, typically we only perform lymphoscintigraphy one time to establish the diagnosis of lymphedema, but it can be used serially, and this is an example of an individual whose lymphoscintigram deteriorated over time because of progression of the disease, it is a potential application, but one that is not used very much except perhaps for research purposes. A more recent adjunct to the imaging armamentarium is so-called indirect magnetic resonance lymphography. So this would use the same principle as nuclear lymphoscintigraphy, but instead of injecting a radio-labeled compound, one injects into the skin the gadolinium bearing compound, which also has obligatory lymphatic transport, and therefore one can see the ascending lymphatic vessels and look not only at function, but also at some of the structural attributes. I must say that this has not received any clinical application yet in North America. It's chiefly performed these days in Europe and in Asia, but it might be coming to the US as well. The beauty of MR lymphography is that we can also see the central lymphatic structures like the cisterna chyli and the thoracic duct. And again, you will be hearing more about this from Dr. Itkin tomorrow in his lecture. The most recent addition to our imaging armamentarium is so-called near-infrared fluorescent lymphography. And this relates to the fact that if one injects a compound into the skin that has autofluorescence and that is also obligatorily uptaken by the lymphatics, then one can use much more simple imaging techniques. And here you see the contrast between a normal limb. This is an individual who has Milroy's disease or a form of primary lymphedema with underdevelopment of the lymphatics, and you can see the pooling of the material in the tissues because of inadequate uptake and transport into the vasculature. This, like radionuclide lymphoscintigraphy, is more of a functional imaging technique, and unlike radionuclide lymphoscintigraphy, which has some quantifiable attributes, this one would be purely qualitative in nature. However, one of the attributes of the technique when applied clinically is that it does show us a progression of imaging pathology over time, and these three patterns have been clinically described. The so-called splash pattern, stardust, and then diffuse, and basically these would reflect either temporal progression or increasing severity of lymphedema as these various patterns become apparent. So there is some utility in the imaging modality in terms of grading attributes of the disease. So there has been some formal study of the sensitivity of these varying imaging approaches for the detection of early lymphedema. Remember, sensitivity is the degree to which one will not have a false negative examination. So The near-infrared or ICG lymphography is 100% sensitive. That is to say, lymphedema will not exist without an abnormal imaging study. Same can be said for MR lymphography. Lymphoscintigraphy, while very specific for lymphedema, is not altogether sensitive. About 30 or 40% of the early cases of lymphedema will actually be missed. And CT, which I haven't shown examples of, is exceedingly non-sensitive. It's a very interesting modality to gauge disease, but it is not very sensitive at all. So the next problem we need to think about is that stage 0 lymphedema. You remember when we talked about the ISL classification, the earliest stage is stage 0, in which there is no physical evidence of lymphedema being present. And this is of particular problem and interest to the cancer survivor population who know that they are at risk in theory for developing lymphedema. The risk never goes away completely, although it is very front-loaded to the first 12 to 36 months after treatment. But these cancer survivors have anywhere between a 15 to 50% potential for the lifelong potential for the development of lymphedema. And as you can see, the accrual is not necessarily immediate, and it is relatively progressive over long periods of time. This creates a tremendous amount of fear and has led to some very extreme sets of advice for patients in terms of activities that they must or cannot indulge in, and we really need better ability to detect so-called latent lymphedema. There is some technology that is now clinically available, I think the most important of which is this methodology of bioimpedance spectroscopy, and it's based upon the fact that if one delivers a biological current to the tissues via a surface electrode, that current will travel through the tissues based upon its intrinsic frequency. High-frequency current will both travel between the cells and through the cells because the current can penetrate the cell membranes. The low-frequency current is excluded by the cell membranes and must travel through the extracellular fluid. Now, we all know we're not supposed to talk on the telephone in the bathtub because water is a great conductor of electricity. So for that reason, bioimpedance spectroscopy demonstrates that the more extracellular fluid you have as you deliver a low-frequency current, the faster the current will travel through the tissues. So if we serially monitor a limb at risk and compare it to a normal limb, if that bioimpedance ratio rises, meaning the impedance is changing in a way that reflects that there's more and more fluid being accumulated, then we have the ability to detect very early subclinical development of edema that will be very extensively sensitive to simple treatment modalities. And there have actually been outcome studies to show that the simple use of a compression garment, a low-grade compression garment, when the bioimpedance spectroscopy becomes initially abnormal, is enough to reverse the tendency to develop overt lymphedema. This is what the monitoring materials look like. These are surface electrodes, very similar to what is used to do an electrocardiogram, and this is the handheld device that actually detects the bioimpedance ratios and does the calculations. It brings up the question of biomarkers as well. Suffice it to say, we don't have clinically relevant biomarkers at present, but it has been a subject of my own research, both preclinically in animal models and more recently in human subjects, and this has now been published. And suffice it to say, in our work trying to identify biomarkers, we've identified some very important pathways that are highly upregulated in the tissues of individuals who have lymphedema, and these signaling pathways include proteins that are secreted into the body fluids and can be measured at sites remote from the locus of disease. So like any biomarker, we do same as PSA. For monitoring prostate cancer, we do a blood sampling remote from the site of disease in order to detect evidence of the disease. And what we found in our work when we did a logistical regression analysis of the data that we were accumulating based on monitoring 56 of the markers that we had identified, It took as few as 6 of these markers to differentiate at greater than 90% accuracy individuals who had lymphedema from those that were normal, obviously blinded and prospectively investigated. And what was interesting is that, although not chosen for this purpose, these markers happen to segregate into the disease pathways that are probably the most relevant to the progression of lymphedema. So we have more work to do in this area, but suffice it to say that there is the prospect in the future for using biomarker analysis, both to detect risk for lymphedema, even perhaps even preoperatively prior to cancer therapeutics, and certainly during that long latent phase when individuals might be prone to developing very early disease. Once we identify the disease process, we invoke some treatment regimens. At this stage in development, most of our treatment, and perhaps one can say all of it, is physical in nature, but it is extremely effective. It is based on the principle that if we detect the disease early enough, we can theoretically prevent its progression to later, more irreversible forms of it. And the approach overall is deemed complex decongestive physiotherapy. It includes a number of elements, including a manual massage technique that increases entry of fluid into the initial lymphatics and thereby increases their upstream contractility. We use multi-layer bandaging to augment that approach in the hands of a well-trained physiotherapist. The patient undertakes decongestive exercise, and there is skin care. The theory behind this is the earlier that we can invoke these therapies, the more we can avert the long-term consequences of the untreated disease. So these are the various elements that we've just talked about. The hallmark of the phase with the physiotherapist is the multi-layer bandaging, which is repetitively applied, typically over 15 to more than 30 sessions over a defined period of perhaps a month or 6 weeks, each session of which is designed to build on the one prior to it and will lead to the fitting of the individual with an appropriate compression garment, which is not meant to reduce the size of the limb, but rather to preserve the effects of the antecedent therapy. There are a variety of compression devices that are now able to be considered beyond a simple axial garment of the type I showed on the slide prior, and for many patients, because of physical constraints and other issues, we have to resort to some of these other forms of long-term compression. Coupled with all of this, in many of our patients, we also use intermittent pneumatic compression, and there is a role for this in the management of these patients. It is not standalone therapy, but is often very effective adjunctively to the elements I just mentioned. There are a variety of devices on the market, and the choices about which one to use will be dictated very much by the medical needs of the patient. The end result of all of this is not cure, certainly, and one could say even the post-treatment effect still represents a sizable disease component, but when one looks at the starting point of the patient, we can see exactly how dramatic these interventions can be. This is one of my patients who, when I met him, was unable to work because he couldn't even put on a pair of trousers or a pair of shoes. And after 3 months of treatment, this is the net result. He's able to wear shoes that he can buy in a store. He's able to put on a pair of pants, and he has returned to work. In aggregate, many studies have shown that these interventions are in fact very effective, not only in reducing edema volume, which has both functional attributes as well as psychosocial attributes, but interestingly enough, although it's not commonly acknowledged, lymphedema in almost all subjects is to a greater or lesser degree painful, and one can show that actually there is a sizable and statistically significant reduction in pain when these complex decongestive physiotherapeutic approaches are applied. So what happens if we don't treat on time or we don't treat properly? Well, lymphedema is, I'm sorry, this doesn't project very well, but lymphedema is a vicious cycle that is a self-propagating one, and is based upon the tissue pathology that's present, much of which we're detecting with that biomarker approach that I alluded to earlier. Basically, we know that all of the attributes of progressive lymphedema have functional consequences to the patient that are really quite profound. And this has been shown numerous times in very quantitative studies about the psychosocial impact and physical impact of lymphedema on the diseased population. So again, the disease starts like this with pitting, but it doesn't remain that way. And with the passage of time, to a varying degree in individuals who are affected, eventually the component of pitting is lost, and this is a reflection of the advent of the structural changes in the tissues that are inevitable if lymphedema is the substrate of the edematous condition. Eventually it can become really profound, and here I think none of us have any problem in recognizing the attributes of this stage 3 lymphedema with the cobblestoning, the erythema, and all of the fibrotic changes that are distorting the skin, and particularly the digits of this affected foot. But it begins very early. This is a child with primary lymphedema, and you can see even at several months of age, the digits have already become irreversibly altered in their structure at the skin level because of the presence of lymphedema that has been there since birth. So one of the attributes of lymphedema is thickening of the skin, and you can see on a cross-sectional MRI of a human thigh that it strongly resembles the cut edge of a grapefruit. So, of course, the skin shouldn't look like this. We can barely see the skin of a normal limb on typical cross-sectional MR imaging, but you can see how many multiples and multiples and multiples of normal skin thickness are present in this individual, rendering the surface of this limb like the surface of a football. And you can imagine what the consequences are to that individual, not only on function, but think about the abnormality of the skin barrier and the likelihood that this skin barrier will have abnormal immune function, will not serve as an appropriate physical barrier to the entry of bacteria and other microorganisms with the prospect of recurrent cellulitis. This is a cross-section at post-mortem of a long-standing lymphedema arm, and you will see here two attributes. First of all, I've illustrated for you again that intense thickening of the skin that is present based on long-standing lymphedema. But notice also the profound increase in the thickness of the subcutaneous adipose layer. This again is a direct consequence of lymphedema and is very recognizable as an attribute of lymphedema. You can tell how heavy this limb was to this individual because of the amount of muscle atrophy that has occurred underneath. This is where the bone used to be. But the fact of the matter is, this woman had a limb that was probably 3 to 4 times normal size based on the contralateral limb, and almost all of it was comprised of fat. There is actually very little fluid present at this stage in the natural history. And this irreversible consequence of lymphedema is one of the beguiling mysteries of the disease that we definitely need to solve. But here's an example of DEXA imaging in a lymphedematous limb. So as you look at the total extra volume of the limb, notice that on average, over 50% of the total edematous volume is actually fat. Some of it earlier on is actually muscle hypertrophy based on the size and weight of the limb. Eventually, the muscles atrophy based upon disuse. And of course, bone volume effectively represents little or none of it. So this is one of the problems we need to solve. We'd like to believe that earlier intervention will slow or perhaps halt the progression of that component. Now, as we know, we have no cure for lymphedema. We'd avidly like to find one, but at the moment, what we have are physical therapies that are very effective at halting progression and perhaps even to a degree reversing the progression. And with that, I'll conclude my first talk. Thank you. And we will have a general question and answer session at the very end of our curriculum this afternoon.